Yeah, okay.
Someone just started the webinar. Now it's recording. You are live.
Yeah, could you actually help us troubleshoot our last speaker?
Yeah, I think Shannon, she's mute. That's why we can't hear her because
She
as
says unable to access microphone. She's
let
typing on
me
the
just
chat right now.
check it. Hmm. Let me just see.
Hi, everyone. Thank you so much for joining us today. We're just having a few technical issues, but we'll start in another minute. Thank you. Yes, please go ahead and post questions in the chat. I'm just going to do a quick introduction, and perhaps during this period, we could take some time to put questions in the chat as well. So my name is Sabina Borja-Miller, and I actually am a longtime supporter of Lymphoma Canada. I used to volunteer for a very long time, and then I sat on the board for 6 years, most recently as the vice chair of the board, and I just stepped down off the board earlier this year. But Lymphoma Canada is an organization that's very near and dear to my heart. I will be the facilitator for this session today, and I'm very pleased to welcome both Dr. Shannon Murphy. We're having just some technical difficulties, but she'll be on board in just a few moments. And we also have Dr. Natalie Johnson, and I know you've heard both of them speak earlier today from our breakout sessions on diffuse large B-cell lymphoma, as well as on Burkitt lymphoma and other aggressive lymphomas. So just as a quick reminder to all the participants, we do have a chat box enabled. The questions do come directly to the hosts and panelists, i.e. to us. So we are seeing your questions. So please take a moment to put in any questions that you have that are still unaddressed into the chat, and I will try and get through all of the questions during our limited time that we have today. I know we have quite a few questions to go, so maybe what I could do is perhaps start with some of the questions we have for Dr. Johnson, and then get towards perhaps having Dr. Murphy section after that. Okay, so just looking through really quickly with respect to the questions that we've received. The first question I have actually came right before, has to do with triple hit lymphoma. And this question is for Dr. Johnson. I have triple hit lymphoma. How does this differ from double hit lymphoma?
So triple hit lymphoma just means that there's an additional genetic change in addition to the MYC and BCL2, but the MYC and BCL2 really are the driving forces for this lymphoma. So there's really no change between a triple hit. It doesn't make it more aggressive than double hit, and it's treated the same way.
Okay, that's great. And I know this question that we just got on our chat could probably go to either of you, so I'm just going to throw it out right here to you, Dr. Johnson. What is the chance of relapse for double hit lymphoma after first-line treatment of DA-EPOCH-R chemo treatment? I'm guessing this actually has to do with DLBCL.
So that's the standard of care for, so the standard, well, there is no real standard of care for double hit lymphoma. There's no clinical trial looking specifically at this because it's an uncommon aggressive lymphoma, but the consensus is that for patients who could tolerate more aggressive disease, more aggressive or intensive chemotherapy. That is what we tend to do. And so that's why we use EPOCH, because it's slightly more intensive than R-CHOP. The chance of relapse is higher than DLBCL. More than 50% have experienced relapse, and at the time of relapse, depending on the time of relapse and where you are in the country, the treatment would be CAR T-cell. So if in many provinces now, that would be if there's a relapse within the first year of your therapy, then that would, and the person is fit enough to get a CAR T, that would be the preferred treatment.
Okay, that's great. Thank you so much. And I think Dr. Murphy's mic is now A-okay. Perfect. So just follow up actually on that same question, a question that we received earlier. And, Dr. Johnson, you've touched upon it. Our EPOCH treatment is more aggressive. So question that we did get was, because our EPOCH treatment is more aggressive, does that mean there are more side effects? And if so, how does management differ with our EPOCH compared to our CHOP? And Dr. Murphy, I'll put that towards you.
Sure. Yeah. So, we do consider dose-adjusted R-EPOCH to be a more intensive therapy. It's also administered differently. So dose-adjusted R-EPOCH is an inpatient regimen because it's infusional. So it does require an inpatient stay. Although during the infusion, patients tend to feel pretty good. But, it does have an additional drug. It is associated perhaps with deeper cytopenias and perhaps an increased risk of infection or febrile neutropenia. It's a little bit more intensive. I'm so sorry, I've lost the thread of the question. Other than the intensity, was there
it's just, how does management, how's the management? Yeah.
Management is really, really very similar. So supportive care, antiemetics, so anti-nausea medication to make sure patients are feeling well. Frequent blood work, so you do get a little bit more blood work with the dose-adjusted R-EPOCH, so twice a week instead of maybe weekly on our CHOP therapy, so that we can watch. Because it's dose adjusted, we're adjusting the doses based on how low your platelets and your white cells go. So we do watch a little bit more closely. So there's more pokes and a few more trips sort of back and forth to the lab. And then, but otherwise management's quite similar. We'll still do imaging in the middle to get an objective look at how well things are going, imaging at the end, and still 6 cycles. So, similar inpatient versus outpatient, and a little bit higher intensity, which is why we tend to reserve it for disease of higher risk.
Thank you so much, Dr. Murphy. And just as a follow-up, another question we received from our attendees earlier was, speaking about infusion therapies, can you explain what infusion therapies are and what the side effect profile looks like? So I know you've touched upon a little of that, but perhaps you could expand a little more.
Infusion therapies, just generally speaking?
In general, yes.
Yeah. So when I say infusional for the dose-adjusted R-EPOCH, it literally drips in through an IV over the course of 4 or 5 days. So it's kind of a steady infusion. Typically, when we're giving chemotherapy treatment, so R-CHOP, for example, a portion of your R-CHOP therapy is IV. So you get some IV drug. So an infusion just means a medication that you're getting on a continuous drip, whether it's going into the vein intravenously or if it's going into the subcutaneous tissues subcutaneously. So how the drug is delivered doesn't necessarily speak to its intensity. It's just the way it's getting into your body.
Excellent. And then one last question for you, Dr. Murphy, before I move on to Dr. Johnson. A question from the attendees has to do with LDH, so lactate dehydrogenase, and they want to know what's the value of monitoring this as part of the cancer surveillance post 6 rounds of R-CHOP for DLBCL.
Yeah, good question. And it depends a little bit. So lactate dehydrogenase can be a marker of cell turnover or cell breakdown. And so that can be indicative of disease growth or cell lymphoma expansion. But it's not specific to that. So it can be elevated for other reasons. So it can be helpful in patients who have sometimes a fast growing lymphoma. Perhaps if it's elevated at the time of diagnosis and then falls into the normal range during treatment, if it were to become elevated again down the line after treatment in surveillance mode, then that may, in conjunction with other clinical clues and the physical exam, that may prompt further investigation. That might be a tweak for your hematologist or oncologist to say, maybe I should go looking. There might be something up, right? It can be, it can sort of set off, not even necessarily an alarm, but it can be a signal to go looking for something. Yeah. Important to take it as part of the full clinical picture, though.
Good to know. Thank you so much, Dr. Murphy.
Absolutely.
Moving on to you, Dr. Johnson, a question that we received is, how often does indolent non-Hodgkin lymphoma become aggressive?
Yeah, I think I tried to answer that in the chat. It's about 3%. The risk of transformation to aggressive lymphomas, approximately 3% per year. So it's uncommon, but if someone has an indolent lymphoma that now has more aggressive or intense symptoms, like a rapid growing node, or they're having new fevers, night sweats, a very high LDH, then we suspect that there might be a transformation, then we would recommend a biopsy to confirm it.
Thank you. And another question, slightly shifting focus over here, but another question that we did receive was, what increases the chance of a patient experiencing cytokine release syndrome after treatment, and what symptoms should people watch out for? And Dr. Johnson, that's towards you as well.
So cytokine release syndrome is a syndrome whereby patients, after getting immunotherapy, typically in the relapse, for the treatment of relapse disease, would get fevers. It can have low blood pressure, requiring oxygen. And these are symptoms that can be graded, and depending on the grade, the treatment varies. And the risk of cytokine release syndrome, it correlates with the disease burden. So the patient who has a lot of disease at the time of the therapy is at higher risk of getting these symptoms.
Thank you so much, Dr. Johnson. Dr. Murphy, I'm going to put 2 questions up to you. So essentially, in the context of someone who's received 6 doses of R-CHOP and PET suggesting no residual disease, how would you work up or monitor upper body itchiness? And a second question to that has to do with surveillance involving repeat MRIs of the brain when someone has also received 6 doses of high-dose methotrexate for suspected CNS.
Okay, so that's
basically on to do with surveillance for both.
Yeah. But the first question was about working up upper body itchiness.
Upper body itchiness that did not exist prior to the diagnosis, but otherwise PET CT suggesting no residual disease. But
yeah. So I guess there, we'd take a good history of the itch, and if there's anything that could be a provoking factor, relieving factors, and a good skin exam. If there's something to see, like a skin change or a rash or, peeling skin, that kind of thing, I often lean on my colleagues in dermatology, and it can be quite helpful to get their opinion. And if there is, a skin lesion or a skin change, a biopsy can be useful. But to have a good conversation about, what that itchiness is and how how it's presenting, and if there's something to see is going to be important before we do anything else. So, anything that you notice in your body that's different after you finish chemotherapy for cancer is going to get your spidey senses tingling, right? You're going to think about, is this cancer coming back? Is this an effective chemotherapy? So having a good conversation and a good look at it would be important. And then in terms of surveillance, generally speaking, for patients who have finished 6 cycles of R-CHOP and have achieved a complete remission, what we would tend to do in our center is follow those patients every 3 months with blood work and a physical exam in clinic. And we tend to follow every 3 months for the first 2 years, and then we transition to every 6 months and follow most patients out to 5 years. And then we do often hand those patients back to their family doctor if there hasn't been any sign of relapse. Of course, we have more and more patients across the country who don't have family doctors, so we are keeping a hold of some of those patients longer than we might typically. For patients who have had CNS involvement and have had 6 cycles of our CHOMP, so R-CHOP chemotherapy and high-dose methotrexate, then the practice of surveillance may vary a little bit. So you hopefully will have had a post-treatment MRI, plus or minus a lumbar puncture. If there were lymphoma cells circulating at the start of your treatment, we're going to check to make sure they're gone at the end, MRI imaging to make sure that's gone. And then some centers will repeat an MRI or repeat an LP. However, many places will be following clinically. So same schedule every 3 months in clinic, clinic visits with a physical exam and blood work. And then you may have a series of MRIs spaced maybe at 6 months initially, maybe at 12 months, or you may be followed clinically depending on your local practice.
Thank you so much, Dr. Murphy. Switching to you, Dr. Johnson. A question that came in has to do with CNS disease for patients with Burkitt's lymphoma, and they would like to know how this is managed.
So an integral part of Burkitt lymphoma therapy is incorporating drugs that penetrate into the CNS. So they cross the blood-brain barrier. So patients are preferably treated with the McGrath protocol. So this, Codox MR IVAC, what I discussed in my presentation, and they would, I think fewer patients would be treated with the EPOC regimen because it doesn't include high-dose methotrexate or cytarabine. So we would treat the CNS disease with these by including the more intensive therapy that include methotrexate and cytarabine and multiple lumbar punctures.
Thank you so much. Another question, sticking with Burkitt lymphoma is we got a question with respect to CAR T, and our participants want to know whether CAR T cell therapy is also available for Burkitt's lymphoma or not.
Unfortunately, CAR T is restricted to specific lymphoma subtypes. So, and Burkitt's is not included. And the reason for this is because the rarity of Burkitt's they just don't have enough patients to see whether or not CAR T therapy is effective in these patients with relapsed disease. And the legislating bodies that fund new treatments really base their recommendations and their decisions on evidence that is provided to them from clinical trials. So if there are no patients who've been on clinical trials, with specific aggressive lymphomas, specific disease in the CAR T trials, then these patients would not receive funding for CAR T. Now, in patients who have means and have $1 million in their pocket, because that's what it would cost. Like I've had a couple of patients who have gone to the States to get a CAR T. They may provide a CAR T for those patients, but I it's never happened to me, so I can't be sure of that.
Thank you so much. Dr. Johnson, coming back to you. Sticking on the topic of treatments, a question that came in asks, when it comes to indefinite treatments versus time limited, is the efficacy of one greater than the other? And how do patients choose, or do they even have a choice in what kind of therapy they want to receive? Sorry, this is for Dr. Murphy.
So I guess in this situation, we're talking about relapsed or refractory disease. I guess the two examples that I would be thinking of would be the bispecific antibodies. So we have two bispecific antibodies that are approved in relapsed refractory diffuse large B-cell lymphoma, one of which is a time-limited therapy and the other is continuous. And we don't know which is better. They're not compared head-to-head. They both seem to be effective for this type of disease. And so, if you're choosing between those therapies specifically, certainly you'd have a choice. Certainly your preference would be taken into account. And that really probably would be the deciding factor. They're given a little bit differently. The schedule is a little bit different, but one is meant to be continued and the other stops. So that your preference and what you are wanting to do in the schedule that you're wanting to follow is always going to be an integral part of the conversation when we're looking for treatment options for your disease. Sometimes, we may get to the point where we only have access to one thing or only one thing is funded, but we're also always going to be looking for the next best thing. So if we don't have what you're looking for, hopefully there will be something in the pipeline or a clinical trial that might be appropriate.
And a follow-up to that question is, speaking about bi and tri-specific antibodies, do more targets mean more side effects as well?
What a great question. I don't know. No, I'm not sure. And actually that might be a good question. Dr. Johnson, what are you knowing in the tri-specific space?
I am not sure. I think it's the type of immunotherapy that will give you a side effect profile. So for instance, CAR T cells targets just CD19. There are CAR T cells that target more than one. They're earlier on, like they're not standard of care. They may have more side effects. It's hard to say, but if you compare the side effect profile of CAR T that only targets CD19 versus a BiTE that only targets CD20, that it's not really the target, it's the therapy itself, I would say.
That makes sense. Thank you so much. Both of you have sort of touched a little about clinical trials. So another question that we get actually very often is from patients who want to know how they can get involved in clinical trials. And so I'm going to open that up to either or both of you in terms of what advice you would have for patients who want to join or be involved in clinical trials.
I think always asking at your local center what's available. And it's very appropriate. If there are clinical trials at your center, then people are going to want to talk to you about them. So expressing an interest. If it's not directly offered to you, asking, are there trials available for my disease? For would I be, is there something that's going to be appropriate for me? That's going to be a good choice. That's going to be effective treatment for my disease, and having those conversations. And sometimes there's not a trial at your center, but sometimes there's a trial at a center within reach, or, there are for patients who are in the community, and we serve a relatively small area that manages to be geographically a bit broad on the East Coast. And so we do have some patients that travel to our center from outside of Halifax to participate in clinical trials. And so that can be an option as well, depending on how far you're willing to go. So I think just having those conversations and asking those questions, we want to help you. So we're more than happy to let you know what's available.
Dr. Johnson, do you have anything to add to that?
100% agree.
Okay.
I think asking your doctor,
Mhm.
and it's the degree of motivation. We run a lot of clinical trials at our center, and in Montreal, and we have patients from Quebec City, Ottawa. Like I even had a patient from Winnipeg that flew in. That's how motivated she was. So it's very variable, but I would say be aware that if patients want to go for clinical trials in the States, it's still very, very expensive.
Speaking about all this inter-province travel for clinical trials, one of the questions I know, Dr. Johnson, you and I have talked about in the past has to do with the availability of therapies between provinces. Why is there so much variability between what therapies are available and or covered between our provinces in Canada? And Dr. Johnson, I know this could be a whole topic of conversation for both you as well as Dr. Murphy, but could you just give us, a brief response as to why this occurs?
Well, there are two bodies that decide on whether or not a drug should be funded. There's CADITH PCODER for the rest of Canada, and in Quebec, it's INES. And so they're independent review panels that review the same literature, but come to sometimes different conclusions. And that results in the disparity. You watch a debate on TV, you can have different opinions of how that debate went. And yet this is where we are. It's frustrating, I think, for all Canadians, because, in Quebec, we have access to drugs that others don't, and vice versa. We don't have access to Pola-BR, for instance.
Definitely is a very complex system. I know that in public health, very often we say if you put 10 public health people in one room, you'll get 12 responses. So that's generally how it works. But it can be so frustrating to know that even though we technically are supposed to have one healthcare system, it's not really one healthcare system, right? So thank you for taking us through that. And we have time for one last question. And Dr. Murphy, I'm going to put this towards you. I will be receiving an autologous stem cell transplant in the coming weeks from my DLBCL. What can I expect in terms of side effects and management afterwards? And what should I particularly watch out for?
This is going to be an excellent question for you to put to your care team. but first of all, congratulations. And in terms of what to expect, so if you're receiving your transplant soon, you will get your cells just like a blood transfusion. And then you'll probably go home. So when we give our autologous stem cell transplants, you receive your cells, we keep an eye on you, and then you're monitored in the community usually for the first 5 or 6 days. And depending on your situation, you may have a supportive care unit or a medical day unit that you'll be going to on a regular basis, where you can have your vital signs checked, your blood work checked. If you're starting to feel kind of crummy, you might need a little bit of fluid. But essentially what will happen is you'll have had some chemotherapy and to bring your cell counts down, and then you'll get your cells, and your cell counts are going to be dwindling. So cell counts are going down, similar to when you've had your chemotherapy in the past. So you may feel similar, you start to be a bit draggy. You may start to have less energy. You may start to feel a bit sick to your stomach. You may start to have some diarrhea. Those types of feelings are probably what you'd expect early on. Many patients will start to have some irritation in the mouth and the mucous membranes, a little bit of, we call it mucositis, or just irritation of the
those mucous membranes, the lining everywhere from your mouth all the way down to your bum can become inflamed. And so you'll be admitted to hospital for supportive care. And that's really to make sure that we keep you as comfortable as possible, that you're getting transfusions because your cell counts are low, and you're getting the protection you need while you're at increased risk for infection. So, you know, you may have some pain, you may have some diarrhea. Those are probably the most common, and you may have fevers, you may have infections, but that's why you're in hospital and while those counts are low. But your care team will be working to make sure that you're as comfortable as possible. So even though those symptoms sound very unpleasant, you will be getting medications on an as-needed basis to help to manage them. So your team will be keeping you as comfortable as possible while your bone marrow works really hard to recover yourself.
Amazing.
I just want to add, sorry, that
Yeah.
some centers for lymphoma, it depends on the regimen they use for transplant. So it's quite possible for aggressive lymphomas that younger patients may get a regimen that requires admission the entire time.
It's good to know.
So it's variable between centers.
Mhm.
Yeah. And
Which is
takes
why speaking
so
to the
long.
care team is really important to know exactly what, to expect. So I think that communication, open line of communication, I think has been addressed throughout our Q&A today. So I think this is a great note for us to end on, is that have that open line of conversation and discussion with your care team, because they're there to help you through the process and answer all of your questions as well. I just want to take the time to thank both Dr. Johnson, Dr. Murphy for being here with us today, not just for your sessions, but also answering all of these Q&As at our Q&A session today. So thank you so much again for the time and your knowledge and the expertise that you've brought and shared with our community. We hope that everyone who's joined here today has learned something to take either about themselves or their family members as well, and had your questions. We tried to get through as many questions as we possibly could today. So thank you so much for joining us, and just wanted to send a quick reminder that the next session starts in a couple of minutes, and it's titled Symptoms and Side Effects Management for Lymphoma Patients. So please make sure that you join us in the next session. Thank you once again, everyone, and have a lovely rest of the day.
Bye.
Bye.